So what to do here in this station? In this station, simply, you are going to, number one, take history from the lady or from the girl. She's coming here because she's having your FY2, definitely your FY2 in GP surgery. The patient is here because of skin lesion and she's having some concern. She needs it to be removed. Talk to her about the daycare surgery. No, you're talking to her about the daycare surgery and discuss about the management plan with her. Special note, none. So you will enter to her and you will ask her about the skin lesion. How to ask about the skin lesion? I need someone to tell me the questions very quickly. What are the questions for the skin lesion? Tell me.
Size, shape, color, and the changes in it.
No, say from the beginning. Say from the beginning.
Like where exactly is the lesion, first of all?
Yeah.
Then the size of it.
Yeah.
Is there any change?
Yeah.
The color, is there any change?
Exactly.
Then the shape, is there any change?
Mm-hmm.
And is it bleeding or itching?
Or ulceration?
Is there any discharge?
Okay, perfect. Thank you, Mercy. Also, you can add one question, is it painful or not? Okay. So here in this state, or in this case, sorry, in this station, you will find that the girl is having this skin lesion since maybe 1 week and no significant anything. No bleeding, no ulceration, no skin changes, no changes in color, no changes in shape, no changes in size, no pain at all. And she doesn't have any lesion elsewhere. What are the important things and red flags not to be missed in the skin lesion station? Dr. Masih, tell me.
Like if there is any bleeding or weight loss.
Weight loss, cancer symptoms, right?
Yeah.
So cancer symptoms, and what else? You can also ask something.
You can ask about
maybe any skin problem, like any skin problem, like any close contact, family, right? Anything related to the skin.
Okay.
Right?
So this is different. This is completely different from a rash.
Yeah, I know, but you just ask this in any skin problem. Like for example, you are ruling out cancer here, and you can also ask about any close contact with anyone. And one important thing as well, I needed to tell you to add here in this station. She is a female patient. Don't you think you should also ask about the period at least?
Yeah.
Okay, what are the specific set of questions for the skin lesion? I mean, now you ask about past medical history and lifestyle. In the lifestyle, in skin lesions, only pick up the smoking and alcohol. Very enough. Smoking and alcohol.
Exposure.
Okay, so now let's start with the specific set of questions for the skin lesion.
Any sun exposure, like for longer time.
Mm-hmm. And what else?
And what else?
Sun exposure is one thing. You know, when we are in UK, they do not have sun, right? There is no sun in UK. So to be exposed to sun, what do they do?
Tanning.
Tanning, which means that they should travel to some tropical country. Right? So you will ask about number one, as Dr. Rumi is saying, number one, travel history. Number two, any sun exposure. Number three, any job. The job. So sun exposure, travel history, and job. Sun exposure, travel history, and job. Okay. Now, you know, when someone is having skin lesion and they are concerned about it, they usually have some concern. Now we are asking about the social aspect of the skin lesion. You know, if anyone is having a skin lesion in their shoulder or in their face or in their neck or anything, definitely they will be embarrassed about it. Do not underestimate these things. They are embarrassing and uncomfortable to any patient. So you are going to ask the patient 2 or 3 more questions. Does it make you feel uncomfortable? Has it caused you any problems? Does it catch your clothes? I mean, if it's in the shoulder or in the back, Does it catch your clothes? So again, does it make you feel uncomfortable? Has it caused you any problems? Does it catch your clothes? By the way, this girl is going to get married in 1 week, and that's why she needs it to be removed. So now let's examine. The examiner, they will give you a picture of skin lesion, red skin lesion, very red, and I mean like it looks like honey color. So this is the examination. Excuse yourself from the patient. Look at the paper. You will find the skin lesion. Back to the patient again. You will tell the patient that from my assessment, it seems to me that your skin condition is benign or skin lesion is benign. So I'm going to talk to my senior and we'll discuss the possibility of removing it and we'll decide in the best possible option. So your mission here is to talk to the senior to find out how you can remove it to her or how you can arrange its removal to her. Okay, if you want, you can tell her also this skin lesion has been there since a short time, no changes, you have not been exposed to the sun, no signs of anything bad or no signs of anything serious, so we can remove it to you. What will be the removal here? It is daycare surgery. What is the daycare surgery, guys? Daycare surgery is simply, here in this case, she will come to the hospital, you know, in this particular day, the lesion will be removed and she will go home as well. So what will happen here? You know what will happen? Simply they will inject local anesthesia. We will tell her that we will give you local numbing agent, which will make you pain-free. Okay. And after giving it to you, after a while, we can start shaving the skin lesion. Procedure we call shaving excision. Shaving excision, which means that I'm sure all of you have seen a minor procedure, like you open the skin above the lesion and then pick the lesion or like try to pick the lesion from inside. And after that, we close the skin with dissolvable stitches or with fine subcutaneous stitches sometimes or some other times fine suturing. So again, local numbing agent, then do shave excision, and after that close the place. And here they will add something called electrosurgical feathering. What is electrosurgical feathering? You know, it's a device which is used to bring the edges of the wound closer. This will limit the scarring and limit the chances or minimize the chances of recurrence. So she will have also some concerns. What will be your concerns? Will it be painful? You will tell her that we will give you numbing agent and we can also inject more numbing agent. Doctor, will it bleed? Chances of bleeding are very slight here. Here for the bleeding, you are going to put something called aluminum hydroxide. The aluminum hydroxide will stop the bleeding right after surgery or will minimize it to the minimum. Doctor, will it be infected? For the infection, we can apply antibiotics after the procedure. And we will also dress the wound or dress the site properly. Doctor will come again. So now we can speak about the electrosurgical feathering, which will help better healing and minimize the scarring. This is number one. Number two, it will minimize the chance of recurrence or lower the chance of recurrence. Okay, doctor, I don't want to have it. May I know why? Doctor, I'm really worried, doctor. It will be, doctor, I can't see it. I can't see it while it's performed. Now you can tell her that you can put screen before your eye to not see what's going to happen. You know, mostly it will be done. By the way, the place of this lesion is on her shoulder. So she's not supposed to see it. However, they can place a screen so that you do not see it. She does not see it. Doctor, I don't want to hear anything. I don't want to hear you nor this device while performing. Okay, simply you can put headphone or earplug. So here she can use headphone or earplug to not listen to anything. Okay, doctor, I will think about it and I will come to you. Usually she will accept what you say. So her concerns are regarding pain, infection, bleeding, and recurrence. This is a station of the benign skin lesion. Very simple and very easy.
Dr. Ahmad,
Yeah?
when it is the coverage for this surgery for the mole, the benign one, does NHS give the coverage for this procedure?
Yeah, mostly yes. You know why? In her case, it will be covered for one reason. One important reason is that she's going to get married. This is number one. Or number two, it has made her uncomfortable. I told you if it's having some some psychological impact on the patient, like making her feel uncomfortable or catching hair closes, definitely at this time you will have to remove it to her. And by the way, speaking of the place, it's on the shoulder, so the chances of catching in the clothes are very high.
Okay.
She will get, yeah, she will get, if it has affected the patient esteem or the patient comfort, you will need to remove it, and you can fund it, by the way. But just do not say to her that the NHS will fund it. No, you will say, I will speak to my senior, and we can reach the best possible plan for it, or the best possible arrangement for it to be removed.
Okay. Okay. Got it. Thank you.
Okay. So, electrosurgical feathering. I will write it. So again, the management, as all of you attended in any ward, it is minor procedure. Inject local anesthesia, which is local numbing agent. This local numbing agent will make hair pain-free, and also it will make the lesion rise. Now, after injection, the pain will be gone, or the sensation will be gone. You will do shaved excision procedure, in which you open the skin over and expose the lesion and then remove it. After that, you will close it with stitches and electrosurgical feathering. And for the bleeding, you will apply ammonium hydroxide. For the infection, you will apply topical antibiotics and you will cover or dress the wound. That's it. And by the way, it can be a little bit painful after if it can be painful, we can prescribe you some painkillers after the procedure. Anyone has any questions so far? Because the next stations are quite similar. Okay, let's speak about the next station here. Next station is the same skin lesion, but it is serious thing. In the next 2 stations, or even 3 stations, or even 4 stations, we are only supposed to follow the same approach. So please concentrate in it, because I do not want you to confuse yourself. They are very similar. Do not be too scripted and do not be too particular. You have to be prepared to any change in the skin lesions, because they change it every other day. I mean, even the photo that you will see right now, they can change it in your exam. Why? Because you need to only to see one thing in you, whether you will say cancer or not. Okay, in the next skin lesion, it is very similar in terms of approach, but there is one thing that you should take care of. Here, there is a change in the size, change in the color, and sometimes bleeding as well. And the color is black.
Dr. Ahmad, my friend Dr. Sama got this station in the outside of cubicle. It was written that patient young, like she developed mole, and when inside she went, and at the point of examination, examiner gave the picture of melanoma. So at that point, Dr. Sama got confused that the management plan would be different in this situation, isn't it, as compared to mole?
What's different? What's different?
So like for the mole, it was benign, but the inside picture was given as melanoma picture. So for
no, wait, sorry. Mole does not mean to be benign.
Okay.
Mole, in the literal or the verbal translation of the word mole means a strange thing.
Okay.
You know, in the English movies, they use the word mole for someone who's a spy or someone who's unconfirmed or anonymous identity.
Okay.
So you can use the word mole for anything which is unknown yet or unproven yet.
Okay.
So you don't know, yes, you don't know till you enter. I mean, if this mole can be benign or can be malignant as well. It doesn't mean that the word mole can mean that it's benign. No, no way. You still have to elaborate that. Okay, so here in this station, the skin lesion is black and it's increasing in size and changing in color, getting darker in color, and it can be bleeding and can be ulcerating as well. Sometimes there can be history of weight loss, some other times no. But usually here in this case, there will be travel history and sun exposure for a long time and sun tanning. And more importantly, the lady or the girl works as landscape artist. That's why she travels through tropical areas and she enjoys sun tanning. Okay, so in this case, I'm going to tell the patient, the examiner will show you a picture of dark brown or brown-black skin lesion. You will tell the examiner that, you will tell the patient that it seems to me a bit serious. Why serious, doctor? So from my assessment, it seems to me that your skin lesion is a bit serious. Why serious, doctor? Because of many reasons. Number one, they have been changed in size and the color. This is number one. Number two as well, you have been exposed to the sun. Okay, and long-standing exposure. And number three, actually, there can be weight loss if it's ever present. So we are going to tell the patient about this. So what are you going to do to me right now, doctor? We are going to refer you to a team of specialists. They are going to take a sample from it. They are going to do the procedure, the local procedure, by removing skin lesion. The same procedure as the previous one, removing the skin lesion and sending it to the lab. By the way, one important thing, the previous girl or the previous station, she can ask you one more question, doctor, is it something serious? Yeah, no, why? Doctor, I'm just worried. Actually, from what you told me, it seems that you have nothing or nothing suggestive of serious. However, to make sure, also one more thing to make sure is that to remove it and send it to the lab. So this is only one other reason we must remove it, or we should remove it. In the previous girl. In this girl, you will tell her that we're going to send you to a team of specialists. They're going to remove it and take a sample from it and examine it under microscopy. She will ask you how will you remove it and how will you take a sample. The same questions exactly like the previous one. Okay? But the moment you will tell her that something serious and her facial expressions will change and she will be disappointed. So please offer sympathy and empathy. I'm sure that it's tough time, but here we still need to do further investigations to find out about that. And hopefully everything will be fine. And even in the worst cases, if it's confirmed, we have a variety of options to offer you. What will be the treatment options here? You know, removal of the lesion, you already removed it, right? We can also remove area of skin around it. Or simply, I do recommend that in such cases, you can tell the patient that treatment usually depends on your general immunity and on your response, and it differs from someone to another and the stage of the growth to another. So it depends on the stage and the grade of the growth. It depends also on your general immunity. However, we usually, after removing the skin lesion, we remove an area of the skin, of the surrounding skin. Okay, this is most probably the treatment options. This is the whole station. So the only change is that you have to tell the patient something, could be something serious, or it seems to me a bit serious. And the same management plan and the treatment depends on the stage and depends on the general immunity of the patient and on the grade of the tumor as well. Okay, next station is quite similar to it. So here it's melanoma, most probably. But in the next case, or in this case that we're going to speak about, it is most probably either squamous or basal cell carcinoma. Squamous or basal cell carcinoma, you should not bother about what to say and how to differentiate between them. Because in both cases, you cannot confirm except after doing biopsy. I really wonder why people keep asking, what should I say? How can I disclose squamous or basal cell carcinoma? How do I differentiate between them? Why? Why do you bother about that? Usually, remember from PLAB 1, anything in the face or in the head most probably is basal cell carcinoma. Most probably. But generally, you should not say this. Just say the same thing. You will be having skin lesion increasing in size or in color, and here it will be bleeding, can be ulcerating as well, beside the travel history and sun exposure as well, and sometimes we will give you history of tiredness. So definitely all this points toward the cancer, and when you get the picture from the patient, you will see the skin lesion. So watch out, by the way, to not mix that, the melanoma is dark brown or dark green, it's dark black or dark brown. So the melanoma is quite obvious. But squamous and basal cell carcinoma, you can also differentiate between them. Just check the photos on Google and you'll find that most probably the squamous cell carcinoma higher chance of bleeding and ulceration, definitely. And the basal cell carcinoma is usually in the face or in the head. But just do not bother about them. What you're going to tell the patient again, it seems to me a bit serious. It seems to me a bit serious. Why? Because the changes and the travel history or sun exposure and the tiredness. What are you going to do to me? Refer to team specialist, take sample, and examine it. Upon which you decide on how to manage that. Which management? Again, the management will removal of the skin lesion and some of area of the skin around it. Sometimes they may decide on giving some further treatment, like maybe some courses of chemotherapy, if it is ever confirmed. You know, after telling him that it could be something serious or could be type of cancer, his face will change and he may cry. That's why you should not tell him in the management that it seems to me cancerous. Don't say this. Just say it seems to me a bit serious. Why, doctor? Because of 1, 2, 3, 4. Doctor, is it cancer? May I know why you think so? Doctor, because 1, 2, 3. Okay, he will tell you any reason. So you will tell him, actually, at this point, it's difficult to say. However, we need to, actually, at this point, we need to refer you to team specialists to find out, to take sample from it and find out the reason. However, I'm afraid cancer is a possibility here. Or you can say even cancer is a high possibility here. You can say that. Just say possibility or high possibility. His face will change. You will keep reassuring him we have a variety of options to offer you. We have good doctors to look after you. Let me tell you what we can do. Now we can discuss the treatment by removal of the skin lesion and some area of the skin around it, and we can give you some further treatment plans like maybe chemotherapy. Sometimes he may ask you again about how to remove this, you know, the numbing agent, and electrosurgical feathering and antibiotics and aluminum hydroxide and the same things again. And please do not forget to say to the patient that the treatment usually depends on your immunity and the grading or the stage of the tumor, of the stage of, just even don't say tumor, just the stage of the growth. Has anyone got any questions so far regarding these two stations, the last two stations? So here you are not supposed to disclose what's squamous or basal cell carcinoma, please. You just say whatever, I mean, it seems to be a bit serious. Anyone has any question? Okay, give me 2 minutes, guys. 2 minutes break. Hello, everyone. Sorry for the interruption. Dr. Massier, I did not speak about the mole behind the ear yet. I'm going to speak about it right now. I just spoke about the melanoma and the basal and squamous cell carcinoma together. Okay? Dr. Ella, you don't need to worry about the skin lesions. I'm going to... Yeah, I know. You do not need to worry about the skin lesions at all. The skin lesions are similar approach. All of them are similar. And I'm going to repeat them again.
No, I'm not worried about the skin lesions. I'm very worried about the back pain.
Back pain. Okay.
Yes.
Okay.
Yeah, but
let's agree on something. No, let's agree on something. Tomorrow I will start the session I will start the session 15 minutes earlier, and I will repeat the back pain for you again.
Okay, then I will leave my daughter at school tomorrow.
Okay, it's just because
I'll pick her up after this.
It's just because.
Thank you very much. That will do. Thank
you. No, actually, it's just because I can't. I did not record the back pain, by the way. So I was supposed to repeat them maybe after the session, but after the session I will have to leave like 15 minutes after the session, so I will not have time.
It's all right. It's all right.
I will repeat them again tomorrow morning. Tomorrow before the session.
Thank you. Yes, thank you. Thank you.
You're welcome. So the thing is that now we will speak about the mole behind the ear, Dr. Massey. In the mole behind the ear, she is coming to complain. Actually, she is not the one, or he is not the one who's complaining of it. He is complaining that his wife had noticed it. Why? Because it's behind the ear, so he did not notice it at all. So every question you will ask, he will tell you, I don't know, doctor, but my wife told me that it is that. Doctor, I don't know, but my wife told me that it is that. So actually, he will give you finding of skin lesion, which is increasing in size, and sometimes, no, not sometimes. Actually, it is he has been exposed to the sunlight, and he has traveled recently to for tropical area. He will examine it, and you'll find a skin lesion like a mole. Mole, what does it mean by mole? Usually, the skin lesions are either red, dark red, or dark brown on black. Here in this case, they can usually give you some brown skin lesion. It will be brown skin lesion. You cannot say even melanoma. You cannot say melanoma. Okay? What you're going to do, here in this case, you're going again to tell the patient that it seems to me a bit serious. Why serious, doctor? Again, you will tell serious because change in size and color and travel history and exposure to the sun. Okay. What after that? What are you, doctor? Is it cancer? May I know why? You would tell him that actually, at this point, we need to refer you to specialists. They are going to take a sample from it to find out the exact diagnosis. However, I'm afraid cancer is a possibility or a high possibility here. See how I say it? However, I'm afraid cancer is a possibility here. Why? Do not say this or the cancer boldly. Don't be bold. When you are saying the word cancer, mind the feeling of any patient. I mean, God forbid, if you are in his or her place, you'll feel the same. So please mind your facial expressions and your voice tone here. Otherwise, I will kill you all. By the way, Dr. Bina, I'm sorry to say, but why are you using two accounts? You and Dr. Safa. I noticed that you use two accounts. Dr. Bina, you're using two devices? Okay. No problem. Okay.
Brother, this is a cancer, not a mole.
Dr. Masih, you were sleeping.
No.
Admit it, you were sleeping.
Pardon me, but...
Admit it, you were sleeping.
No, I'm confused. Whether it's cancer or a mole.
No, okay. Again, the mole does not necessarily mean something benign. Mole means something unrecognized. So mole means strange body, or strange finding, or something unconfirmed, or something unidentified. So what I'm going to do right now...
Because I got this station.
Huh?
I got this station and I just told the patient that to me it looks like a mole, and I asked him, is it bothering you? He said, no, doctor. The thing is, my wife just wanted me to just go to a doctor and see whether it's something serious or not. So I just told him that to me it looks like a mole. So if it's not bothering you, then let it be like that. And if you're worried about something, then I can have my senior again here and have you reviewed again. So he said, yeah, that doctor, that's fine.
Dr. Masi, tell me what was your score in this station? I mean, you didn't disclose to him
I
the
think
you didn't disclose to him the
no,
possibility
I
of
think
cancer.
no, not at all. I think I scored 4 or 5. I failed this station.
Yeah, good. You relieved me because now I know that I was explaining it in the right way. Because if you get high mark in this station without mentioning cancer, this means that this is not right. Here, Dr. Masih, simply, I told you that if there is a skin change, lesion change in terms of color or size or whatever, please do mention the possibility of cancer. Many people are confused. I need you to open the dictionary right now, the Urban Dictionary. Open it, and you'll find that the word mole means in the language, in the English language or anything, not even medical, something strange. Which means that still you have to figure yourself out. So please try to focus on what the patient is saying, because if you are definitely those people are not stupid. They are not telling you that it's benign from outside. They are telling you mole so that you go inside and you discover by yourself. So when you find there are skin changes in terms of size and color and travel history or sun exposure, you are going to tell the patient that we need to do further investigations by referring you to a team of specialists, and again the same procedure again. Exactly, Dr. Zaid. Focus on what the patient is saying, because actually this patient has been exposed to the sun and he has noticed some changes in the skin lesion in terms of size or color. And this usually doesn't happen in the benign lesions. So when he asks you why serious, doctor, you tell him because it has been changed in size or in color and you have been exposed to the sun. And I'm afraid this is not the case with the benign lesions. Okay, this is the mole behind the ear. So what you want to extract from all the skin lesion station, you have to ask sun exposure and travel history, very importantly. Okay, let's speak about one more station which come recently. And by the way, please, I need you to point out one line in this station. Anyone who's not having notes with them, please try to point out this line with you. Why? This station is not found in any script and it's coming recently. And unfortunately, many people are confusing it and failing it because they do not know it. And it is also another skin lesion. The only challenging thing in this station is that the patient is taking methotrexate for their rheumatoid arthritis. And the patient here is concerned because they think, okay, here the concern is that the patient think that he will tell you, doctor, please, I need to stop my medication. May I know why? He would tell you, doctor, because it gave me this skin lesion. Or this skin, like black, like skin spot. It is not necessarily a lesion, it's just a spot, like oval spot. Okay, now you have to elaborate the skin problem. Since when it starts, like any skin problem, but the problem is that you will find that it has been changing in size and in color as well. So it has been changing in size and in color. Not only this, sometimes it could have traveled as well. So this guy has traveled. So what do you think? This can be because of the medication? Actually, now in this case, the patient is concerned that this is a side effect of the medication. And from your elaboration, you found that there are signs of malignancy by change in size and in color. So what you can do here, you will tell the patient, you will examine it, and the examiner will give you a photo. And then after that, you will tell the patient, again, it seems to me a bit serious. May I know why? He will ask you, may I know why? You will tell him because it's change in size or color and sun exposure as well, which is not the case for the benign lesions. You tell your doctor, but it could be a side effect of the methotrexate I'm taking. I have a very good idea. Why don't you start your disclosure by opening the BNF? You'll open the BNF and you'll find that the methotrexate can cause some skin problems. Yes, that's true. But the thing is that you have to know that these changes are most probably suggestive of malignancy. I mean, yes, skin problems can occur with methotrexate, but they are not showing any malignancy changes. But here, unfortunately, the patient is showing malignant changes. So what you can do, after disclosure and you are referring him to a team of specialists, you will also tell him that I may consider with my senior reviewing your medication because the chances of methotrexate causing skin problems are present or are possible. So you will refer him to specialists to take a sample from the skin lesion, and also you review his medication and possibly may stop it because it can cause some skin problems as well. You will do two things here. Okay, take a sample and stop the medication. You refer him to specialists, or the team of specialists to take a sample and stop the methotrexate as well. So here, the most probably is that it's not only because of the medication, it's here could be some malignant problems. So same disclosure, same approach, but just at one point that you need to review the medication because it can cause a skin problem as well. Just to make sure. This station, you have to ask about the travel and sun exposure, and you have to open the BNF. Please try to open the BNF. Just put yourself in the place of the people who got this station for the first time in their exams. What should you do? Only open the BNF. You will find that the skin lesion, by the way, this station is quite short. The skin lesion station can finish in 6 or 7 minutes ultimately. So you still have time to open the BNF. I hope this was clear a little bit this time. This is the only difference between this station and the previous station. Now the skin lesion stations are over. Anyone has got any confusion regarding the skin lesion stations? So for the benign, you will say it seems to me a benign. But for the possibility of malignancy, you will say it seems to me a bit serious. Okay. Yes, you'll find BNF on. Actually, you know, if they do not bring you BNF, it will be their mistake. I mean, it's not your mistake, it will be their mistake. So please be ready to the BNF in almost all the cubicles. Okay. Okay. So anyone has got any question before we move? Speedy? You think it was too speedy? If change is malignant, I didn't get this question. Yes, if change is malignant and if no change is benign. And also, even if there is no change, but there is prolonged sun exposure, now you have to be a little bit worried. But usually, you know, with prolonged sun exposure, there will be change in the color. So definitely change in the color is a consequence of prolonged sun exposure. Okay. Anyone has got any questions so far? Yeah, presents on all curriculum. Dr. Kashi, this is what we spoke about in the first benign skin lesion. She was coming because she wants it to be removed because she's getting married in 1 week. Remember? That's why you will talk to your senior to find out the best possible decision or the best possible plan to remove this for her. She's entitled to remove it, by the way. Drawing papers? No, we will not have drawing paper. Actually, what will happen? Oh, you mean for the shaving excision? For the shaving excision, actually, maybe sometimes they can provide you with a paper to draw how the excision is done. Okay, let me demonstrate it to you. I need a blank paper to show you how it's done. It's very simple. I mean, just, like shave, like you're shaving it. Wait. Okay, I hope it's clear, but I think it will not be clear. Okay, this is just a diagram. I think it's not clear here, but simply how you shave skin lesion, this is how you shave it from the sides, one side and from the other side, like this. You're shaving like this, see? Like this, around and one around. Now it's exposed, right now you can remove it. This is how you can do it. This is sometimes can happen. I mean, to be provided with it in the cubicle. Okay, those are the skin lesion stations. Wait, guys, 1 minute. Okay, let's move to the other stations, which are the EC stations, like the cystitis and the UTI stations. Okay. So in this case, in the cystitis station, she is presented with burning sensation or she's presented with dysuria. Dysuria, this is a task. You're FY2 working in A&E or sometimes GP, and the patient is presented with dysuria. Okay, so in this case, I need someone to elaborate it to me. Guys, this is definitely like UTI. It's actually UTI. So this is definitely like the normal elaboration of the UTI that we spoke about before. Can anyone elaborate it? Dr. Ella, I need you to elaborate it to me. I'm coming with dysuria, doctor. I'm having burning sensation in my urine. Dr. Ella.
I hear you. Yes, hi.
So, can you elaborate that to me?
Yes, would you please tell me since when you're having this?
Okay, wait, I have to tell you something. Sometimes the presenting complaint is burning sensation urine, and sometimes it can be lower tummy pain. So tell me how to elaborate the lower tummy pain.
Okay.
Oh, now you have a festival. Happy Easter.
Yeah, to whom? No, I mean, you elaborate just pain, how it started.
Okay, you will find, let me tell you, the pain, okay, you can mute yourself right now. I see that you're having some time. Okay, no problem. Mute yourself right now and your next station will be yours. Okay, mute yourself. So I need someone to come with me in this station because I'm going to ask them for some few questions. Dr. Maria, and after Dr. Maria will be Dr. Manisha. Dr. Maria?
Yes, I'm here.
Okay, the patient is having lower tummy pain just below her umbilicus, and it's not going anywhere, and it's not relieved with paracetamol, and it's getting worse day by day. Hour by hour. And the pain is dull aching pain. What's your next step?
Would you please tell me something more about this?
About what?
About the tummy pain?
No, actually, no. After finishing the elaboration of the tummy pain, What will be next?
Okay. So, anything else?
Yes, doctor, I have got some burning sensation in my urine.
Okay. Since when you got this?
Started maybe yesterday, doctor, and it's getting worse as well.
Oh, okay. Do you think something else like frequency? What about your frequency of urination?
You say frequency to the patient?
No,
Just
I
say,
don't say.
no, yeah, just say, for example,
How many times you go to the loo?
No, simple. Have you noticed that you go to the loo more often?
Oh, okay. Have you noticed that you go to the loo more often?
Yes, doctor, I started going to the loo more often yesterday. So, symptoms of UTI are frequency, dysuria, and urgency. Do you feel that you need to run or rush to the toilet or to the loo?
Okay.
Very simple. So, she will give you burning sensation, and sometimes she can give you frequency, and some other times nocturia. Okay, Dr. Maria, what are your differentials here? What are your differential diagnosis? And give me one question or two questions to each of them.
Okay, my differentials of UTI. Oh, it's a case of UTI. It's
Tell me, what are your differentials?
Okay, it could be appendicitis. Okay, so I'm gonna ask
not
about
really, not
fever
really,
and
not really. You know, the pain is not
because
shifted.
it doesn't move. Yeah, it's a dull aching pain.
Yeah, and it's not shifted. You mean the umbilical pain, which shifts to the right iliac fossa, is appendicitis, but here it's not.
Yeah.
Cystitis is a diagnosis, Dr. Moiba. Dr. Moiba, cystitis is a diagnosis. Okay, so tell me what are your differentials?
Obstruction?
No. Okay, let me point out some things to you. Here, a red flag to any UTI, red flag is pyelonephritis. As Dr. Nigar just said. This is the first thing you should ask about pyelonephritis.
Okay. No.
Okay? Okay. This is number one.
So I'm going to ask about the fever and...
Exactly. Fever and shivering or loin pain.
Intensity of the pain would be more.
Fever, shivering, loin pain. Fever, shivering, loin pain. Those are for the pyelonephritis. What else could be the other differential diagnosis?
Renal colic?
Okay, I can say renal colic as well, but you know, the renal colic is actually is excluded from the pain itself. Okay, but okay, it's fine. I will tell you how to exclude it right now in the past medical history. I need you to ask me what the DDs right now.
Okay. So, do you have any fever with shivering? Like, do you have high-grade fever?
Okay, now you ruled out pyelonephritis, Dr. Maria. What are your other DDs?
I told renal colic.
Okay, what else?
I don't know actually.
PID?
I'm confused. Yeah, PID. Yeah, she's a lady. Yeah, PID.
Okay, PID and ectopic pregnancy as well, right?
Ectopic pregnancy. Okay.
How to ask about ectopic pregnancy and how to ask about the PID?
The same, like the fever, and about ectopic pregnancy, I would ask her about the period. When was the last period?
Yeah.
Oh, you're laughing. Am I funny?
No, I'm not about you actually, because Dr. Nigar told BPH.
Okay.
You know, BPH, benign prostatic hyperplasia. Okay. So,
okay.
so tell me. So PID,
so
you told me.
I'm gonna ask about the period. Like, when was the last period?
Okay, perfect. And what else?
And about the pelvic inflammatory disease, I'll ask the yeah.
Okay, let me point out to you. Just don't worry and don't confuse yourself. If you are confused, it's fine. Okay, I have a good idea. PID, what's BD, Dr. Zain?
Discharge from the front.
What's the vaginal situation? Okay, so I have to tell you one thing. Here in this case, I have to pick. There are many differentials actually, not only one or two differentials. But the most important to not miss ever is the pyelonephritis, Dr. Maria, because this is the red
Okay.
flag. This is the most serious thing, the most serious complication to any UTI.
Yeah.
This is number one. Number two, Dr. Maria, what are the other differentials? Number one, PID. Number two, ectopic pregnancy. Number three, as well, I can ask about any constipation, because constipation is one of the triggers for UTIs, right?
Okay.
What else, Dr.
Right.
Maria? Could be renal colic, right?
Right.
Okay. So, Dr. Maria, to ask about these DDs, what we can do right now? You know what to do. Number one, I asked her about the fever. I asked about the loin pain and the shivering, and it came negative. So I should now ask her about the other relevant thing. For example, have you noticed any change in your bowel habits? No. So now I ruled out other GIT problem. Number three, let's speak about your period. When was your last menstrual period? 2 weeks. So now I excluded ectopic pregnancy. Any painful period? Any heavy bleeding? No.
Yeah.
So I excluded PID. Any discharge? No. So I excluded PID. I excluded PID and ectopic pregnancy in one go. And before that, I excluded pyelonephritis by 2 questions. And from the presenting complaint, I picked up that it is cystitis by 2 words. That there is dysuria and lower tummy pain. Why it is not renal colic? I tell you why. Because if the pain is present since 2 days and there is burning sensation in the urine which started yesterday morning, do you think that someone with renal colic can stand this pain for 2 days?
No.
The renal
Cannot
colic
wait for
is a
this
colicky
long.
pain. They are rolling in their bed.
Yeah.
So right now I'm going to ask the patient from the past medical history in a previous episodes. No, this means that probably this is not renal colic, because most of the people with renal colic has got previous episodes, and they will tell you I have got renal colic before.
Okay.
Recent health. How was your health recently? Nothing significant. Medical conditions. Do you have any medical condition? Any urinary problem or any kidney problem? No. Do you take any medications? Any allergy? Here I have to ask about the allergy. You know why, Dr. Maria, I have to ask? If you told me why?
About if I'm going to prescribe her the antibiotics, I need to rule out the allergy for that.
Perfect, perfect. You know what? If you keep answering right way, this means that Dr. Mahdi is obliged and forced to bring you a gift.
No, he didn't brought any gift for me.
No family issues here. Okay?
Okay. I'm off. Okay.
Okay, yes. Here is the study class. Do not incriminate your partner, please.
No,
okay,
no.
so right now we have to ask this question. By the way, guys, I need to point out I was kidding, but what I was saying to you is that the people who are not asking this question in this station are going to fill the station. The allergy station is the allergy question is a must in this station. Why? Because the task here tells you that you have to write a prescription form.
Okay.
Again, you have to ask this question, guys, in this station. If you do not ask this question, you're going to not pass it. Okay, I hope this was clear.
Yeah.
Okay, so now you'll ask the patient family history. No. Ask about lifestyle. What's the most important lifestyle? Smoking, diet, alcohol, physical activity.
Diet.
Okay. You asked about everything right now. Don't you need to ask, or don't you need to add one more thing which can be related to UTI in females? You know, actually, most probably sexual history is a close association to the UTI in females.
Yeah.
So you need to ask her, are you sexually active? Yes, Dr. Rivera, exactly. Are you sexually active? Do you practice safe sex? Why? Because unsafe or unprotected sex is a trigger factor for UTIs in female, especially in female. A very good point here is to ask about the sexual history. Why? Because this is very important in the next station. Okay, so now what? You will do some examinations, including tummy examination, right?
Right.
Okay. You can also do some in the tummy examination, you'll find usually suprapubic tenderness. By the way, guys, this station recently sometimes come as a combined station. So sometimes they can tell you, doctor, do the examination on the mannequin. You will only do abdominal examination. You will only do abdominal examination. So be prepared. If you find a mannequin, don't worry. You can also verbalize the vaginal examination, the PV. Okay, now move to the investigation. Which investigation you need to do, Dr. Maria, and without which you cannot reach the diagnosis?
Urinary, man?
Urine, exactly. Urine what?
Routine urine?
Yeah, urine
Routine
dipstick.
urine.
Urine dipstick. Yeah. Urine dipstick will show
Okay.
you some leukocytosis and some RBCs.
Okay.
Okay?
Okay.
So now you know that it is UTI, right? You will tell the patient that you are having, it seems to me that you're having condition I call urinary tract infection or cystitis. What is this, doctor? Can you try to explain to me? What is cystitis or what's urinary tract, lower urinary tract infection? Or what's urinary tract infection?
It's the like inflammation in the bladder wall and the urinary tract wall.
Okay, simply it is an infection which occurs in the bladder and surrounding structure to it.
Okay.
Why did I have it, doctor? Here, she can be having many reasons for it. But most probably here, the cause is the sexual intercourse. Maybe she's having multiple partners. Maybe she's having unprotected sex recently. So if she's giving you that she's sexually active and she's having stable partner, ask her your partner shows similar symptoms or not. Even if he does not show, you still have to suspect that the reason is due to sexual intercourse. Okay, what are you going to do for me, doctor, right now? She's having pain. So what are you going to give?
I will give her some painkillers.
Okay, perfect. What about the fever that could be present?
Paracetamol.
Just say we are going to give you something for your high temperature.
Okay.
Okay, what's next?
I'm gonna do some further review and I'm gonna prescribe
Antibiotic,
drug,
right?
Antibiotic.
Okay, now comes a problem. Sometimes this lady is trying to be pregnant. Whenever you ask her about the period, she's going to tell you, doctor, I'm just, by the way, I'm just planning to be pregnant. So if she's planning to be pregnant, and she will also give you a history of folic acid intake. So she's planning to be pregnant and she's taking folic acid as well. There's a problem here. Now you better prescribe to her amoxicillin.
Okay.
In this case,
I need to open the
excuse me?
I need to open the BNF with
Yes, you will find your voice is breaking, by the way. Your voice is breaking. Yeah, this is perfect. That's what I recommend. But the problem is that in the BNF, you will find that the amoxicillin or the penicillin generally and the cephalosporins are recommended, unless there is allergy. So what if there is an allergy to the condition or to the penicillin? What will you prescribe here in this case? If she is penicillin allergic, first of all, let's assume that she is not penicillin allergic. Let's assume that she is not penicillin allergic. Let's assume that. So what will you do?
Okay. Not allergic. Okay, then I'll give her the amoxicillin.
Amoxicillin, yes. Let me tell you the dose because you need to write a prescription, and I will tell you how to write a prescription in this case.
Okay.
Okay. So in this case, you will write. You prescribe trimethoprim. You cannot prescribe trimethoprim. Maybe he will mark you down in the management, but I mean you cannot prescribe here trimethoprim because listen, if you prescribe trimethoprim, this means that it could affect her folate or her folic acid. This is long term. But if she's having allergy to amoxicillin and you prescribe amoxicillin, this means that you can kill her right now. Right? Amoxicillin 500 milligram BD for 3 days. 3 days. This is what you are going to write on the prescription. Or better, what I do recommend is that because this is a prescription form for the patient, and I noticed it some other way actually, okay, daily for 3 days. See the difference between them?
Okay.
There you got it?
Yeah.
Okay. So you are going to prescribe for her antibiotics. What are the warning signs you need to give her regarding the antibiotic? You need to take this antibiotic regularly as prescribed, even if your symptoms are gone, or if your symptoms are eased. Okay, Dr. Maria?
Yes, okay.
So she needs to take them even if her symptoms are gone. What else? Now I need to give her some lifestyle advice. What are the lifestyle advice, Dr. Maria? You know what? She should drink plenty of water.
Yeah, drink plenty of water.
Right? Not only this, she should stick to protected
Avoid.
sex. Protected sex or safe sex is essential for her, at least till her symptoms recover.
Yeah.
Okay?
Okay.
Okay. So she will drink plenty of fluids and water. She will have. She will stick to the protected sex. Okay. And what else? It's advisable actually to avoid wearing tight jeans. Avoid wearing tight jeans. Okay, and also always go to the. Try to pass urine after having sex.
Okay.
Try to pass urine after having sex. Okay. So do not wear tight jeans, and go to the loo after having sex and pass urine, and drink plenty of water as well. And when she is wiping herself, okay, try to wipe yourself from front to back.
Oh, yeah.
Those are the lifestyle advices that you can give to the patient.
Okay.
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 Okay. So what are the warning signs? Yeah, I told you that she should avoid sex at least till her symptoms get better, Dr. Elvira. What are the warning signs in the end that you can give to this patient?
Anytime you have severe pain, come back to us.
Severe pain and what else?
Severe pain and high-grade fever.
Yeah, and shivering. And if you're
Shivering.
so if she's having severe pain or high-grade fever, or if she's unable to pass urine, come back to us.
Okay.
Okay, guys, I will give you right now some minutes break. It will be at least 5 to 10 minutes as well. Okay, I'm sorry for the delay again. Okay, we'll add 15 minutes in the end of the session because this session will end at 8:15. Okay, so I will have to take a break.
Hello? Has anyone had this session? Can they share their experience, please?
Yeah, I had this session.
Would you please tell me how did it go?
Sorry?
Would you please tell me how did it go? The lady, was she sort of very much in pain? Was she friendly?
No, she was he was cooperative, yeah. And everything went like the script. But I prescribed her, I think, nitrofurantoin or primethoprim. But she was allergic to some medication. She was taking some medication. And I didn't prescribe the medication also. But still I passed it.
You failed or passed?
He passed.
I passed this.
You listen.
Yeah, I did not. What?
You said that she was allergic. She was allergic to
No, no,
what? And
no.
also,
She was pregnant. No, she was pregnant, and she was taking this folic acid. So she was trying to be pregnant. She was taking this folic acid. So I had to prescribe her amoxicillin, but I
yes.
didn't prescribe her amoxicillin. Instead of that, I prescribed her either trimethoprim or nitrofurantoin. And
Yeah.
instead of prescribing her that medicine on the notepad or whatever was there, I didn't do that because I forgot about it. I didn't mention the warning sign also, not some safety netting, but still I passed this session.
Well, maybe she liked you. Was she actually pregnant, or she was planning to become pregnant?
She was planning to be.
It's a
She was
big
planning.
difference. Okay,
No,
thank you.
she was planning to be.
Okay. And someone else
Mhm.
had this. Zaid?
Jai,
Dr. Zaid, did you have it as well? Okay.
Hello, everyone. I'm sorry for the delay again. Hello, Dr. Zaid, you were asking one question. I'm sorry. What do you mean by she was planning to be pregnant now? No. What?
No, this question wasn't for you, doctor. This wasn't because we shared the topic after you left.
Oh, yeah. So what was the question?
No, we were discussing because Dr. Masih had a case, and Dr. Elvira asked him about whether she was pregnant or she was planning to become pregnant. Yeah.
Okay.
It was simple chat, Yeah.
Okay. So I hope this was clear. By the way, the change is that sometimes she is having allergy to the amoxicillin. So what you will do right now, Dr. Masih? She's allergic to
We'll give her
amoxicillin.
clarithromycin.
Huh?
Clarithromycin.
Yeah, tell me.
She's allergic to amoxicillin. You can give her clarithromycin or erythromycin.
Excuse me? I can't hear you.
Like if she's allergic to amoxicillin, then we can give her clarithromycin or erythromycin.
No. Clarithromycin is more for chest infection, okay?
Okay.
Dr. Masih, I have to tell you something. If she is allergic to amoxicillin, at this point, here comes a confusion. Some people disagree about that. Some people say you should prescribe yes, exactly. Dr. Bina, you are absolutely fine. One point I need to tell you that if you open the BNF, you will find that you can prescribe nitrofurantoin. She is taking folic acid and she is trying to be pregnant, and she is allergic to amoxicillin. If she is allergic to amoxicillin, you can shift to the nitrofurantoin. But the nitrofurantoin is not safe. No, it is safe because it will be given only for 3 days. So can you imagine? 3 days course is not a big deal. Here, in this case, you can give nitrofurantoin. And some other people say cephalosporin as well, but I'm not sure which cephalosporin. So this is the problem. I'm not sure which cephalosporin. So what I do recommend is that you stick to the nitrofurantoin. It's just 3 days course. By the way, the nitrofurantoin can be used anytime except at term. I mean, when she is going to give birth. So nitrofurantoin can be given normally. So simply give her, I recommend that you give her nitrofurantoin. I know someone who prescribed cephalosporin and he got, he did not write it in the prescription because his time was over, but he just prescribed cephalosporin and the examiner gave him 2 in the management. So I think cephalosporin can fit as well, but I'm sure that nitrofurantoin is still safe here. So if this ever comes to you, you're going to write nitrofurantoin. Which nitrofurantoin? It will be 200 milligram twice daily. 200 milligram twice daily. This is the nitrofurantoin. So you are going to prescribe nitrofurantoin, guys. That's what I do recommend, in this case particularly. And the course for nitrofurantoin will be for 3 days as well. 200 milligram BD. Sorry, 100 milligram BD. 100 milligram BD. So nitrofurantoin is 100 milligram. I hope this was clear here. What if there is another twist or there is another scenario for the UTIs? She is 16 years old girl or 15 years old girl even sometimes, and she's having recurrent UTIs. Every time they give her different antibiotic, and after a while she comes with UTI as well. It is the same scenario exactly like the cystitis, The only difference is that she's getting more previous episodes of the cystitis. I mean, she's having the same complaint, but more than once. Previous episodes as well. No matter how much they give her antibiotics, she still has UTIs after a while. I mean, she recovers and have UTIs. Recovers not completely and have UTIs after that. I need someone someone who really can think about it, and someone can volunteer and tell me what could be the reason.
General like advice, hygiene, or probably.
So you mean that she's having some problem with her hygiene?
Probably she's not following the advices given
Excuse
to
me?
her.
Your
She's not
voice-
following the advices that were given to her.
Perfect. This is one reason, and actually this is the most important reason. Dr. Rumi, can you think of other reason? Open your mic and tell me quickly. Dr. Rumi? Okay, no problem. Anatomical problem? Could be a reason. Exactly, unprotected sex, which is hygiene. So what we call this condition, guys? No, not vesicular. Dr. Maria, actually vesicular reflux could be one reason, but most probably in children. I mean, up to 12 or 10 years old. Dr. Mahdi, I need a name for this condition. I need a name for this condition, unprotected sex, for a girl who is having her first sexual...
Okay, it's honeymoon cystitis.
Perfect. Mostly, thank you, Dr. Muniwa. This is what we call sometimes honeymoon cystitis. This is the thing. What is the honeymoon cystitis? It is usually cystitis due to the first sexual relationship. Usually when they are having their first sexual intercourse or first sexual relationship, they are not aware about the hygiene and they are not aware about how to take care of themselves. So they end up having cystitis. You know the problem is that in this case, when you say urine dipstick in the investigations, the examiner will tell you no finding, or they will not answer you. So here, what history? Simply, it is definitely like the cystitis history, the station. But here you have to focus on the sexual history. And you have to focus as well on the hygiene. Do you clean yourself properly? Do you wash yourself? So here, please add in this station in the recurrent UTI that you have to focus on sexual and hygiene measures. Okay? In the investigations, there will be no findings. There will be no findings. Actually, she's having cystitis more than 2 weeks. She has got one episode 1 week ago and one episode this week, and this is the third episode. And she's following the treatment and she's following everything. So what do you think would be the reason? Any infection has two causes. Number one, infection. Number two, hygiene. So now we will tell, in the urine dipstick, the examiner will give you nothing. So what does this mean? This means that there is no infection. This is something due to hygiene. I mean, there is no bacterial infection. This is definitely due to hygiene problem. So you will tell her that for this, I'm suspecting you're having condition I call honeymoon cystitis. Or I do recommend that even if you do not mention the honeymoon cystitis, is that you tell her that your problem could be due to some lifestyle problems, or could be some like, for example, some wrong habits you're having. Which is, now we are going to tell her the wrong measures that she is following. Like, for example, the unprotected sex, she should clean herself from front to back, and she should wash herself and go to the loo right after having sex, and do not wear tight jeans. Okay, that's it. So here, I'm going to give her hygiene measures all the time. What if the examiner tells you that there is positive? I mean, like, for example, leukocytes and RBCs in the urine dipstick. This means that it is refractory cystitis, as Dr. Elvira is saying. So if there's a finding in the urine dipstick, this means that there is something really infectious. And now I need to give her 7 days course of antibiotic. Which antibiotic? Most probably, maybe trimethoprim. So again, if there is no finding in the urine dipstick, I will just give her hygiene measures. But if there is finding, I will give her long, like 7 days course of antibiotic with general measures as well. Okay, those are the UTIs for the female so far. Regarding the UTI in the male, what is the most common cause of UTI in old age female and old age male, Dr. Murad? Dr. Murad, this is your first time to share with us. So tell me, what is the most common cause of UTI in old age, not old, like maybe 50 years old male patient? Guys, please, whenever I'm calling someone, try to answer me quicker. I mean quicker than this. Okay, Dr. Safa, tell me, are you here?
BPH, brother, BPH.
Yeah, exactly. So for BPH, after elaborating, by the way, the guy will be presented with some tummy pain and some burning sensation in the urine as well. And when you ask him, do you have anything else? He will tell you, yes, doctor, I'm having, for example, he goes to the loo more often. So now you will know that this is UTI on top of BPH, right? What are symptoms of BPH? How can I ask? Number one, do you go to the loo more often? You already asked, told you. Do you have any blood drops in your urine? Are you able to hold your urine before going to the loo? This is urgency. Sorry, do you feel that you need to rush to the loo? This is urgency. For the hesitancy, I am telling the patient that do you feel that you have to wait before your urine flow or urine starts to flow? For the incomplete emptying, I'm going to ask the patient, do you feel that you do not empty your bladder properly? So just 2 or 3 questions from the prostate problems or the prostatism signs. And usually they are positive. What are your differentials here? Number 1, the red flag for any UTI, pyelonephritis. Number 2, I have to rule out cancer as well. Prostate cancer. How to rule out prostate cancer? Simply loss of weight, loss of appetite. Lifestyle, smoking, diet, alcohol. There is one thing to be added in the male. So we added sexual history in females. And also you can ask sexual history in male, like 1 or 2 questions only. But here you know that the cause is BPH. But what is the most important thing to ask in male as well after the lifestyle? There is one question you need to ask, or I need you to know.
Which one, brother? Which question?
I need one question to be asked to a male with UTI or a male of prostate problem. One question after the lifestyle. The job. Job actually is very important in male. Why? In any urinary complaint, I have to ask about the job because sometimes, I mean, despite I know that the problem is prostate, but still I need to make sure that nothing is wrong with the urinary bladder. So I'm going to ask the patient, what's your job or what do you do for a living? And what was your job in the past? Remember the lung station? So I told you in the introductory session, in the lung and urinary problems, we have to ask about job. Exposure to certain chemicals can cause this problem. Okay. So now I know that's the reason, or I need to do some examinations, like tummy examination. Okay, I am having tummy pain and burning in the urine. I need someone to tell me which examinations, or I will say them to save time. The examinations here are tummy examination, and please mark and highlight that you need to do perirectal examination. The examiner will give you subcrapiopic tenderness on tummy, and he will give you smooth, regular enlargement on the prostate on both sides. So this is UTI on top of PPH, quite obvious. do urine dipstick in the investigations, the examiner will give you leukocytes or RBCs as well. You will tell the patient that you're having urinary tract infection due to, please, here I need you to notice one important thing. The time here in this station is quite limited because you have to ask many things. You have many findings here. You have UTI symptoms and you have prostatic symptoms. So here in this case, please, I need you to focus on telling the patient you are having a condition we call UTI, urinary tract infection, because of what? Because of simply a condition we call benign prostatic hyperplasia or benign prostatic enlargement. Doctor, what is it? Okay, now we'll explain the UTI and how it is related to the BPH. Like what? Like, for example, this is an infection in the urinary tract, which is the bladder and surrounding structures. Okay, and this is usually due to the enlargement in the prostate. The prostate is simply the walnut-sized gland just located under the bladder or below the bladder. Usually when it's enlarged, this compresses on the outlet of the bladder, and this creates a good media for the bugs to grow. Again, it's walnut gland on the base of the bladder. When it enlarges, it presses on the neck of the bladder, and it prevents the urine flow or limits the urine flow, which creates a good media for the bugs to grow. That's why you develop this UTI. Okay, now what is the treatment for this guy? Again, we are going to give him some painkillers, some anti-sickness and anti-feverish medications as well, and some antibiotic. Which antibiotic here? We can give nitrofurantoin simply here. Okay. One important thing here to do is that after managing the UTI, and you'll give him some lifestyle advice like drink plenty of water here, it's very important here to address the BPH as well. For the BPH, simply what you're going to do, you're going to run you are going to do some PCA for a specific engine, and you will refer him to specialist. Remember, you refer him to specialist for transrectal ultrasound and biopsy and CT. So you will do PCA, PSA, and you will refer him to specialist for transrectal ultrasound and what else? And CT of the prostate. According to the test results, we can give him some medications. Which medications? We can give him tamsulosin to relax the bladder. Okay, so tamsulosin to relax the bladder, and finasteride as well. Finasteride actually will be given to shrink the prostate. So tamsulosin and finasteride. Again, finasteride. I'm writing it. Okay, what can I warn this patient about? Again, signs of pyelonephritis, if he develops any of them, and I can warn him about smoking as well, because usually the smoking is the most important cause for the benign prostatic, or one of the reasons which worsens the benign prostatic hyperplasia as well. So again, I will warn him about like some lifestyle advice. I mean, warning signs will be some lifestyle advice for the UTI. No need to use a BNF actually, because there is no time here for this station. But you can simply tell him that I'm going to check with my book after prescribing the antibiotic, or after saying the antibiotic. Usually, I recommend always opening the BNF, but here in this case, it's not a prescription station, and as well, you will not have time because you still have to prescribe or have to describe the BPH. For any benign prostatic hyperplasia, you do PSA, and you refer the patient to a specialist to do stress with biopsy and CT scan on the prostate. Warning signs here will be signs of pyelonephritis and smoking. Okay, let's move to some other station as well. Which station? Now we are going to move to the hematuria. Single episode of hematuria in 60 years old patient. Single episode of hematuria in 60 years old patient. You know what does this mean? This means that this is a high possibility of cancer, bladder cancer, even if it is single episode of hematuria. 2 episodes of hematuria. Just single episode of hematuria is very enough to suspect cancer bladder. And bravo, Dr. Maria, that's right. It is bladder cancer even if single episode of hematuria. And usually it is painless hematuria. Dr. Maria, you are answering very good today. So come and elaborate it with me right now. Okay. Dr. Maria?
Yeah. Hello?
Hello.
You think I'm answering very well today, but actually I'm sick today.
What's wrong?
Actually, I'm having a severe headache.
I'm so sorry to hear that. Are you comfortable to talk?
No, I guess no.
Okay. So Dr. Mahdi?
Yeah, Mehdi would do for me.
Okay. Dr. Mahdi?
Okay. Yes,
Dr. Mahdi?
I'm here.
Um,
No fear, I'm here.
No problem. So I will ask you one question. What if someone is having there is a noise. What if someone is having some episode of blood in his urine? What will you ask?
Oh, I'm so sorry to hear that. I'm so sorry to hear that. For how long? For how many episodes do we have to see this?
Okay, that's good. So number of episodes is number 1. Number 2, if there is any blood clots or not, right?
Yes, yes.
Okay,
And
very good.
is that in the initial stage of urination or in the later stage?
Oh, you mean initial or terminal hematuria? Okay,
Yes.
good.
And then I would ask for any pain, any burning
Why don't you
sensation.
ask anything else?
Like I would ask about the cancer symptoms.
Why don't you ask anything else?
Okay.
Why don't you
okay,
say?
yes. I need to
Because
ask anything
we
else.
always
Yeah.
focus on what
question.
you are going to ask, not what the patient wants to say. Okay,
Okay.
so what else? What could be the associating symptoms, Dr. Mehdi?
Yes, then he could have some cancer symptoms, and then he could have some sickness, maybe sickness, and sometimes like any infection, and for that he may have some burning sensation, and yes, and nothing else, maybe nothing else.
Perfect. So I need to tell you a very short summary for the hemoptysis station. Sorry, for the hematemesis station. Number
Yes.
1, I will ask the patient about any pain while passing urine. No. So now I know that this is
No.
painless hematuria, right?
Yes. Yes.
This is number 1. Number 2, I will ask the patient any fever. Why? To rule out any UTI as well. This is number 2. Number 3, I am going to ask the patient about the prostate symptoms.
Yes.
Like for example, any frequency, any incontinence or any incomplete emptying of the bladder. So 2 or 3 prostate symptoms. Here, I need to ask in this station. Okay?
Yes.
What are the reasons for any blood in anywhere in the body?
Sorry?
What is the reason of passing blood in anywhere in the body? For example, someone who's having bleeding from the nose, someone who's having bleeding from vomitus or any bleeding from the ear. What could be the reason for any blood?
Okay, he may have some bleeding disorder.
Exactly.
But his age is I guess more than 70 or 60, so he should not have any bleeding disorder.
Okay, you just ask about it because he can be taking some blood thinner, like Dr. Masih.
Yes, of course, yes.
So okay, so instrumentation as well, any instrumentation.
Yes.
Okay, any blood disorder, any trauma. So now the differential diagnosis are number 1, the prostate symptoms and infection. So infection, number 1. Number 2, prostate symptoms. Number 3, which is the more important, bladder cancer. How to ask about bladder cancer, Dr. Mahdi?
Okay. First of all, do you think that you are losing weight?
So simply, are you losing weight?
Yes.
Do you feel any shortness of breath or any loss of appetite? Those are the bladder cancer symptoms as well. So now I have to ask about three things. Number one, infection. Number two, bladder. Number two, cancer. Number three, prostate symptoms. And in the past medical history, I will ask him about any blood thinner and any blood disorder and any instrumentation or surgery before in the front passage, right?
Yes.
Why? I need to add one more thing to you, Dr. Mahdi, if you allow me. Is that I need also to tell you that you need to ask about any previous episodes. Why?
Okay. Yes. Initially, my first question was this.
Okay, this is very good.
One.
One important thing to ask here. Actually,
Okay,
I'm sorry. Have you had any renal stones
okay.
before?
Yes, PMH1.
Yeah.
PMH1.
So have you had any renal stones before? So in the past medical history, I have to ask four questions. Number one, about the renal stones in the past. Number two, about any blood disorder and the medical disorders. Number three, any blood thinners as well. Number four, any instrumentation or any injury.
Okay.
Any family history of any bladder problem? No. Lifestyle, smoking, alcohol, physical activity. Very important as well.
Travel history or anytime travel in the Africa. Okay.
Wait. One important question I told you to ask about any urinary symptom. Urinary symptom in male. We have to ask about what?
Any instrumentation?
In male. Job. See, all of them are saying job. But you forgot to say job.
Okay. Job. Yes. Okay. Yeah.
Why job, Dr. Mahdi? Why job? Why job?
Okay, because it is any rubber factory is important, because any type of dye factory is important.
Yeah, you mean aniline dye, right? If I'm not mistaken.
Yes. Yes, aniline dye.
Yeah, aniline dye is one risk factor for transitional cell carcinoma of the bladder.
Yes.
So very simple. You are going to ask him, may I know what you work? Like, for example, have you worked in any industry or chemical factory?
Yes.
He will say no, or he can say yes. Which examinations to do here?
I would like to do your vitals, your general examination, and your abdominal examination and parectal examination.
Perfect. Nothing conclusive. By the way, I have to tell you one trick here. You have to notice it. Sometimes the examiner will give you bilateral benign prostatic hyperplasia.
Okay, but this is bladder cancer, because any type of hematuria
uploads. Seriously, uploads. I like it. Seriously.
Okay. Okay. Any type of hematuria and age more than 60. Okay.
Yeah. What is the problem if any man, you know that most of the men after 45 years old are having BPH. So BPH,
yes.
I mean, BPH has nothing to do here. The hematuria is the most relevant thing. Why? BPH is very rarely presented with hematuria. But I mean, the hematuria here usually happens not due to the BPH. It's usually due to, sometimes I suspect, bladder cancer. So here, please, you are going to tell the patient, I mean, you are going to do investigations as well, including urine dipstick, at least.
Yes.
Urine dipstick will show RBCs, prominent RBCs. So you are going to tell the patient, it seems to me that you are having a problem in your bladder.
Yes.
Which problem, Dr. Mahdi?
Okay. From what you have told me and from what I have done, from what we have done,
your voice is breaking.
You have some. Okay. From what you have told me, can you listen me?
Yeah.
Okay. From what you have told me and from what we have done, you may have a problem in your bladder.
Which problem, doctor?
Yes, at this point, it's difficult to conclude. However, we have to run some tests, and for that reason, we have to run some tests for that.
Which
if
test?
The test result. Okay, initially, I would like to do some blood tests, including your full blood count, to see whether you have any weak blood or not.
Okay.
And then I would like to do an urine dipstick test to see whether you have any blood or not. And
okay.
And I would like to do say any PSA. Yeah, like to do enzyme which is called PSA secreted by your
Perfect. Perfect.
like prostate, and
Yeah.
then if all the test is towards what I'm thinking, at that point I would like to send you to a specialist to do another test.
Okay, which test, doctor?
Okay, our specialist may consider to do a test which is known as cystoscopy, which is a camera test.
Wait.
Okay.
It's not only about the bladder here. You also have to do the prostate tests.
Okay.
You mean
For
the truss, yes, and the truss, and after that the cystoscopy as well.
Okay.
You have to do both things here.
Okay.
Okay, so cystoscopy is the most important thing as well, definitely. So keep going. What is cystoscopy, doctor, or what is this test?
Okay, cystoscopy is a camera test, especially which one small tube or is narrow tube will be inserted through your small passage. A camera is in the top of the tube.
Why, doctor? Why are you going to do it to me, doctor?
Okay, because you may have a condition. It will allow us to see whether any abnormality like any tumor inside your bladder or not. Moreover, we will be capable to take some sample from any lesion.
Simply, Dr. Mahdi, to visualize the inside of your urinary tract, especially your bladder. To visualize the inside of your bladder, okay? If there is any problem inside. And it may also enable us to take a sample from it. Right, Dr. Mahdi?
Yes.
Doctor, could it be cancer?
May I know why do you think so?
Doctor, because my friend Doctor has got bladder cancer as well after some blood in the urine.
Oh, I'm so sorry what happens to your friend. However, whatever we have done, it could be cancer is a possibility, I'm sorry to say. However, we have to run some tests to do.
Why don't you start by saying we need to run some other tests to find out the reason?
Okay.
However, I'm afraid cancer could be a possibility.
Sorry. We need to run some tests to say you confirmly whether it is cancer or not. However, cancer is a possibility.
Okay. I have to add one thing, guys. I mean, this is my personal opinion here. Thank you, Dr. Mahdi. And actually, by the way, the warning signs here would be the smoking. He has to stop smoking, definitely. We'll advise him about smoking. Those are the warning signs here, the smoking. Dr. Mahdi, I need to add one thing. Here you can tell him we need to do further investigations to find the reason, like the cystoscopy I mentioned. However, in the best cases, it could be like simple infection or infection in the waterwork or in the urinary tract. However, in the worst cases, cancer could be a possibility. So you can play it the other way around. I mean, here, like in the lung stations or in the cuff stations, you can tell the patient in the best cases it could be infection. However, in the worst cases, cancer could be a possibility. You can say it this way, or you can tell him we need to do further investigation as cystoscopy I mentioned. However, I'm afraid in the worst cases, cancer could be a possibility. Very simple. Anyone has any questions so far? Anyone has got any problem here? Okay, so let's move to the next station, which is the IV fluids calculation. I know that many people are confused about this station. I bet most of us are not taught this station in the right way. Why? I bet that most of the people are understanding it in the wrong way. Most of the people do not know either how to calculate the fluid or they do not know how to prescribe it. Most of the people do not know how to write it and how to explain it. That's why recently they brought it as a teaching station. How teaching? You will teach your nurse colleague how to run the flows. Let's start. Here, simply this station is about a child, a girl, a small girl, like 4 or 5 years old girl, and she is set for appendectomy. So here, your mission is that you will talk to her father, or you even talk to the nurse colleague to find out the history of the patient, and you will discuss about the NPO and the IV fluid prescription. Here, the task tells you that the patient will be set for fluids for the 24 hours. So she will receive IV fluids for the next 24 hours because NPO has been decided. What's NPO? Means nil per os, which means nothing to be taken by mouth. Okay. When you enter the cubicle, by the way, the task also say that each fluid bag comes as 500 milli. So one fluid bag equal 500 milli. Okay, and there is dextrose 5% and NaCl normal saline 0. I'm writing it to you 0.9%. One important thing is that when you enter, you will take some history. For example, how can you are talking to the father or your nurse colleague, whatever. It is very similar. I mean, it is the same almost if you are talking to the father or the nurse colleague, because the father is a biology teacher, so he can understand about dextrose and sodium chloride and these things. So you are talking to him, what happened? He will tell you that she had some tummy pain and vomiting, and she came here to the hospital. They diagnosed it with appendicitis. What was done? They gave her some medications and they did some tests, and they will set her for a surgery. Now elaborate the vomiting. How much did she vomit? You will know that, or you will notice that she has been vomiting like more than 5 or 6 times. What is the consequence of frequent vomiting, Dr. Nigar? She's vomiting much. What could be the complication here? Hello? Okay, so if someone is vomiting much, I need to warn them or I need to rule out the dehydration. Exactly. So ask about the dehydration. You can find that she is not able to tolerate fluids sometimes. So this is another reason for the nil per os. So here I will put her on NPO for 2 reasons. Number 1, dehydration. Number 2, because of the operation itself. You know, anyone before the operation will be put on NPO because of the anesthesia. The general anesthesia will relax the GIT muscles. And this, if this ever happens, this means that the fluids can move or can pop out of the GIT to the respiratory system. So they can have aspiration pneumonia. So if anyone is having or is undergoing any operation, we need to put them on NPO for the general anesthesia. And there is also one other reason in this case, which is the dehydration in her case. So now the father will push you, I mean, you will take some history from him. Like, for example, does she have any other medical condition? Does she take any medications? How was her birth? Is she up to the birth questions? Then tell the father that, may I know what's your concern? He will tell you, doctor, I need to know why are you giving her the fluids? Why aren't you feeding her? You will tell him that she has been decided to be put on NPO. Do you know what it is? NPO simply is nil per os, which stands for nothing to be taken by mouth. Do you know why? Because of 2 reasons. Number 1, general anesthesia, and you will explain what the general anesthesia will do. Number 2, because of she's having dehydration and she's not able to drink anything or take anything by mouth. So doctor, when you leave her like this, won't she eat anything? Now you will tell him that simply we are going to give her some fluids as drips in her blood vessel. Which fluids, doctor? Now you can explain to him. There are 2 types of fluid to be given. Number 1, dextrose, which is a sugar. Number 2, sodium chloride, which is a salt. I need someone to give me smart explanation for the dextrose and the sodium chloride. Just give me 1-line explanation for each one. I need you to work on that because this is the most interpersonal skill that everyone is lacking. The most interpersonal skill everyone is lacking is when it comes to explaining in simple words.
Dextrose would be sugar.
Yeah, it is a sugar. Why? Why you need to give her dextrose?
For energy.
Yeah, energy provider for long-term surgery or for any surgery, right? So to provide her by energy. What about the salt?
To maintain the balance electrolyte.
Yeah, so simply this is a salt to maintain the chemicals and the balance in her body and to maintain the blood pressure or her blood pressure. So one is a salt and one is a sugar. Very simple, and he already knows about them anyway. How are you going to prescribe? Here comes the challenge. So now you will tell the father, I'm going right now to show you how we are going to determine or how we are going to give her these fluids. How are you going to do this, guys? Let me demonstrate to you what can be done here. Okay. Now, I will send you right now a photo of my paper. Here, I mean a photo of my paper in this station. Give me 1 minute, because I need you all to follow it. Because when you are following it, I'm going to explain it to you, to all of you. This is a little bit can be confusing to some people, and some people, even some academics, differ about them. I mean, they disagree about it. Why? Why? I will show you right now. This will be the prescription form. I'm going to take a screenshot from it and send it to you. Oh, shit. Wait. I'll send it to the WhatsApp group right now. Wait, the guys, through. Check right now the WhatsApp group and you'll see how it works. All of you check the WhatsApp group right now. So now you will see that for the first 10 kilogram, this is what I marked it because I could not get full paper for it. I could not get a full paper for it from the NHS website. So this is what I could get. And actually this is quite similar to what's inside the cubicle. I mean, do not mind about the, you see the hint? There is a hint written on the top left for the first 10 kilogram, 100 milli per kilogram, and next 10 kilogram. Do not mind about this. This is an illustration to you. I mean, provided by our academy. But this is not the case. I mean, it will not be present in the exam. So you have to memorize that for the first 10 kilogram, you will give 100 milli per kilogram, 100 milli fluids per kilogram. And for the next 10 kilograms, you are going to give 50 milli per kilogram. And after that, you are going to give 20 milli per kilogram. For example, if the weight is 25, this means that for the first 10, I will give 100 for each. So 10 multiplied 100 will be 1,000. So this is 1,000 milli. For the next 10, I'm going to give 10 multiplied 50, which means 500 milli. For the next 5 kilograms or the remaining 5 kilograms, 5 multiplied 20, which means 100 kilograms. So the total is 100 plus 500 plus 1,000, which means 1,600 milli. As you already see in my by my handwriting. Now you can follow it, right? There is a section or a column written, I mean the allergies, and the allergy and any other medication, you will just write space. You know the space like this, like I'm going to write right now, like this. Like this. Name, date of birth, and weight and hospital number. They will be provided by the father or the nurse, or they will be written on a table, on a paper by your side on the table. Now you will write the date of your exam. The route, you will explain him. The route will be as a drip in your inhaled blood vessel, which means IV, intravenous. You can write intravenous even here, not necessary. You can write intravenous, I mean as a word, not just 2 letters, no, as a word. Type of fluid. What you are going to write here. See, I will give here, for example, 1,600 milli. And you know that each fluid bag comes as 500 milli. Dr. Maria, can you tell me what, for example, can you guess now how many bags I'm going to give to her? Just guess.
Hello?
Yeah?
Hello? 3 bags?
3 bags, exactly. No, not Dr. Nigar, not 4. I will tell you why. 3 bags of fluids, right, Dr. Maria?
Yes.
Okay, perfect. So I need to give her 3 bags of fluid because this will be 500 plus 500, wait, 500 plus 500 plus 500. What about the remaining 100? Negligible. Remaining 100 will be, yes, insignificant or negligible. They will not make a big difference or no big significance here. You know why? Because I'm going to give these 1,600 or 1,500 milli over 24 hours. So definitely by the end, like by the last hour, she'll be absolutely recovering and absolutely fine. So here, see my paper or my hand notes, my handwritten notes. See what I write? I write type of fluid under the column of type of fluid. I written normal saline 0.9%. You can even write here NS. NS like this. NS. Or you can simply write like this. NaCl. 0.9%. But if you write sodium chloride, you have to write it like this. Capital letters, big case. And after that, you write dextrose like this. Of course, with the concentration. Sodium chloride 0.9%, dextrose 5%. See, in my handwritten notes, I wrote number 1, normal saline. Under it, 5% dextrose. Please, here you have to give 3 bags, 3 fluid bags. So, for example, if you are going to start with normal saline, this means that this will be the sequence as the following. Number 1, you will start with the normal saline, number 1. Number 2, you will give dextrose after it. Number 3, you will give normal saline at the last bag. So 1 bag of normal saline, 1 bag of dextrose, and the last bag is a normal. You will be switching between the bags. This is a discrepancy between some academies. Why? Because some academies say that the bag comes as normal saline with dextrose. They are mixed in the same fluid bag. Some others say no, there's separate normal saline and separate dextrose. Usually what you can do here, okay, what you can do here in this case, simply, you're going to give normal saline and then dextrose and then normal saline all over the day. In clinical practice, what we do, we attach 2 cannulas one on the right side and one on the left side, and you're going to switch between them. How? For example, you will set the normal saline on a rate and the dextrose on a rate. You will be altering between them. This is a problem because actually here is a confusion. So if some people from Swami, particularly Swami, can see what he has written, because I did not check Swami notes. I just checked Samson and Dr. Hammond and Aspire. But what I know is that in the real life, in the clinical practice, we switch between the flows. Like for example, in the same time, I'm giving normal saline and dextrose. But I'm setting it, for example, it will be like one drop from here and then one drop from here, one drop from here and one drop from here, one drop from here and one other drop from here. Okay. So here the rate here, I mean, you will just write on the prescription form this thing: normal saline, dextrose, normal saline, like this, because you are giving 3 bags. You start with saline, this means that you end with saline. If you start with dextrose, you end with dextrose. I mean, you are switching between the fluid bags. Total required amount, you write the calculation, it's 1,600. It differs, of course, according to the weight of the patient. Additives, just write space. The rate here, I will divide the total amount by 24 hours. See, here I wrote above, the rate is 66.6 milli per hour. So you divide 1,600, which is a total, by 24, which means 66.6. Signature, write your first and surname. For example, you write, maybe even you can write just your surname here in signature. This is fine. If you are teaching the nurse, you are telling him the same thing, the same procedure. This is not different at all. We just changed it. Why? Just a change, simple change. Nothing significant here. So this is the station of the IV fluid so far. Now we're going to move to another category of stations, which is the cancer or the pain management. We will do the pain management, both of them, in 15 minutes. And after that, I will definitely move to the post-operative hemiarthroplasty and pain removal and ankle sprain. I will be left with the post-operative wound infection. The 2 post-operative wound infection, I will leave them tomorrow together with other 4 or 5 surgery stations. They provide a calculator, yes. Would we memorize this in case there might be? No. Dr. Ofudili, I told you that this calculation changes every time. There will be a calculator. There will be a calculator, definitely. It's not a mathematics exam, it's not physics. You have to calculate and you have to, I mean, usually this is what happens in the clinical practice, definitely. You know, they can't change the weight anytime. Okay, let's move to one interesting station, and please, the people from, wait. I'm having back pain since 5 weeks, which is getting worse, and it's not going anywhere else. It's just back pain, okay? This pain is getting worse. I tried some paracetamol for it, and it didn't help me. Again, I tried some paracetamol for it, and it did not help me at all. And Dr. Yasmin, I told you, it doesn't go anywhere else, and it's just dull aching pain. And I don't have anything else. No other symptoms. What could be the associating symptoms that you are going to? Dr. Elvira, I will tell you right now. I will tell you. So what could be the associating symptoms?
Yeah. What's the age of the patient?
The age of the patient is maybe 65 years old.
Okay. So associated symptoms, I will ask here. First of all, cancer symptoms. It could be, in my mind, it could be one of the meds in the bed.
Why don't you ask her? Why don't you ask her? Do you have anything else?
Yeah, that is the thing. I am asking that question, that do you have anything else other than this back pain?
No, doctor, no. I don't have anything else apart from this back pain. But you know, doctor, I have been diagnosed with breast cancer 2 years ago.
Okay. So, for after that, you had this back pain for 5 years.
Yeah. No. The breast cancer is for 2 years.
2 years ago, but this back pain, for how long this back pain is?
Maybe 5 or 6 weeks.
5 or 6 weeks. Any investigation done?
Doctor, actually, doctor, I have been diagnosed with breast cancer and I've been receiving chemotherapy.
Okay.
Doctor Yasmin, tell me, do you think she will be diagnosed with breast cancer without investigations?
No. For back pain, any bone scan or MRI done so far?
No.
Because for
No.
2 weeks, saying 2 weeks pain.
I just need you. Wait.
Pain later you are looking for.
No, wait. I'm not. I'm speaking about something else right now. You asked me about anything else. I told you no, but I'm having breast pain or breast cancer since 2 years, and I'm receiving chemotherapy for it. And doctor, I think it's not well controlled. They told me that it has spread many places or elsewhere in my body.
Okay. I'm extremely sorry for that, and I just want to know that any other investigation done for this?
Doctor, nothing else, doctor.
Okay. And you said it's a dull pain. In a scale of 0 to 10, 1 to 10, where 1 is minimum and 10 is maximum, how severe it is?
The score you can say is 8.
Okay, it is 8. And are you getting any, how it is affecting on your life? It seems like it is.
Perfect. Doctor, I can't do any activity. I can't walk my dog. I can't do it. She will give you anything. She keeps speaking too much, by the way. Dr. Yasmin, I need you to give me only one red flag to rule out.
Okay. To rule out.
Yeah.
Okay. Are you having any difficulty in controlling your pee or?
Thank you. Thank you, seriously. Thank you. The cool equine. So what else? One more question.
And are you having any difficulty in,
No.
sexual activity?
I mean, like, no other DD, other differential.
Or differential diagnosis. Then cauda equina, mats of pregnancy. Malignancy.
Yeah.
Mats of malignancy.
What else?
And third.
Neurological symptoms of the lower limb, like weakness in your lower limb.
Yeah. Any numbness or tingling, weakness in the
Okay. So now, Dr. Yasmin, you asked 2 or 3 questions for the associating symptoms, right? One is for cauda equina and one for the neurological manifestations of this prolapse. They are very enough. Very enough in this case. Why? Because definitely you know that is not UTI. I mean, you can ask about UTI, but it's not so relevant because the back pain is since 5 weeks. You think it can be UTI? No, I don't think so.
No.
Okay. So here in this case, the past medical history, I told you the most relevant thing, which is the breast cancer. Any family history of anything else? No. And actually, no need to elaborate the family history in details. Lifestyle, smoking. You can ask about smoking and physical activity, which is restricted. Why? Because she's having this back pain, right?
Yes.
Which examinations to do?
I will do neurological examination for the lower limb here, and SLR and backache specifically, of course. Backache, back examination, SLR. If the patient is male, then if the patient is male, then DRE also.
Perfect.
And lower limb neurological.
Perfect. The examination findings will show nothing.
No bony tenderness, nothing?
No.
Okay. So then investigation. In investigation, MRI is needed here.
Yeah.
And bone is scan. And bone is scan. All body bone is scan.
Okay, the examiner keeps silent.
Okay, then I will disclose to my patient that Mr. Ahmad.
Mr. Ahmad, she is a breast cancer. Okay, just say any female. Okay.
Mrs. Ahmad.
Yeah.
Okay, Mrs. Ahmad, thank you for providing me the information in history. And after doing examination and looking into your investigations report, it seems like you are getting a back pain in the back, which could be originated from the bone, and that might cause of due to different reasons. But as you have a history of breast cancer a couple of years ago, it need to be evaluated furthermore, investigated furthermore.
Doctor
For
Yasmin,
that,
very simple, very simple. Wait.
yeah.
I suspect that the cause of your back pain is due to the spread. I'm sorry to say, the spread of the cancer or the growth from your breast to your back, which is a common association or common complication.
But you didn't get the MRI report yet, Ahmad.
Yeah, I know. I didn't give the MRI report, but what I suspect here, Dr. Yasmin, is that it's definitely because of this thing. If I'm getting the MRI report, I need to confirm it. I mean, this is confirmed, but I say that I'm suspecting it is because of this.
Okay, I'm suspecting. Okay.
Dr. Yasmin, she's having one concern. Doctor, okay, I know that my breast cancer is already progressing, but I need you to manage my pain. What can you do for my pain?
First, like you told me that you have tried paracetamol several times and it's not working. So I need to give you some painkiller which is stronger than this. And, we can follow with that. Will it be okay for you?
Hello?
Will it be okay for you for the stronger painkiller?
Sorry, I didn't get that. The voice was interrupting. Which painkiller?
Okay, so as you have tried already paracetamol several times and it's not working for you, so I'll give some stronger painkiller, that is paracetamol mixed with some codeine, that is known as cocodamol. Will it be okay for you?
Okay, doctor. Okay.
Yeah. Do you have any concern about that?
Yeah, doctor. No, actually, doctor. Thank you.
You're welcome.
Dr. Yasmin, you will give morphine. Not today. You know why?
Why?
It's very good to follow the pain ladder, but here in this case, most of the people who are having advanced cancer, and this is sort of palliative pain management. You will end up giving morphine. Why? She scored the pain. Sometimes she scored 9 for you.
Okay.
Very high. And one more thing as well. She will likely receive morphine after a while.
Yeah, later on. Okay.
So now you will give her. You know why? Because this is counseling station. Actually, this is not history-based station. You have been taking history maybe for 5 minutes. No, you should take history here only in 3 to 4 minutes. Why? I got this station, by the way. I got 9 in it. And one mistake I made, I will tell you right now.
Okay, so hospital admission and morphine, because morphine will be given in the form of IV or infusion, isn't it?
Wait. I will tell you everything. So for now, let me continue the station. So you are going to, I'm going to give you, you told me that you are taking some painkillers. I'm afraid that they are not helping your pain. So for now, I'm going to give you another strong painkillers after discussing with my senior. Which painkillers, doctor? You will tell her we are going to give you a medication we call morphine. Morphine? No, doctor. Why you give me morphine? Now, you know she will change 180 degrees. You will tell her that we need to, because you score your pain high, and I'm afraid that this is high pain and you cannot live, and this is what the best painkiller in your case. Doctor, but I don't want to take it. May I know why? Doctor, I've heard very bad things about it. What will you say, Dr. Yasmin?
Okay, can you please tell me what you have heard about?
Exactly. So now you know why, if you keep saying the side effects without asking her what have you heard, you will end up speaking about all side effects, and maybe you will end up not addressing her concern. So she will tell you, doctor, I have heard that it causes drowsiness. Okay. You will say to her that actually you're right, drowsiness is one of the side effects of the morphine. However, let me assure you that this is temporary in the beginning. For that, we are going to give you some few advices. What will you give me, doctor? Please, again, for anything which causes drowsiness, do not operate heavy machinery. Do not drink alcohol. Do not sign important documentation. Do not stay alone, especially when you are first taking it. Doctor, but what are the other side effects? Other side effects for the morphine, like any painkiller, constipation. How to address the constipation? Constipation can be addressed by sticking to simple meals, and also we can give her laxatives after a while. One other complication or one other side effect is dry mouth. For dry mouth, we are going to advise her to drink water, enough water, and we can give her some some artificial saliva or chewing gums. This is for the dry mouth. So now I have dry mouth, drowsiness, and constipation. What else?
Dry mouth.
The most serious side effect is breathing problem.
Yeah, respiratory depression, yeah.
So if you have any breathing problem, please come back to us.
Okay.
This is a warning sign. Doctor, please, doctor, is there anything else apart from the morphine? May I know why? Doctor, because I have to attend like a wedding one week later, and I'm not sure about this pain. You will assure her that this painkiller will work as soon as possible, and as long as you take it regularly, it will ease your pain. I mean, sorry, it will protect or it will prevent you from having pain. So basically, she needs to take it regularly as prescribed because this will prevent her from having any pain. Okay, doctor, is there any alternative? Now at this point, actually you're having two options, which is the fentanyl patch and the morphine infusion. You know, the pump. The pump here is very important, and together with the fentanyl patch. She will tell you, she will ask you two questions. Is there any alternative to the morphine? When she asks you any alternative to the morphine, now you can speak about the fentanyl patch, because this is a totally alternative or a totally other option than the morphine.
Yes.
What are the fentanyl patch? He will say we can have or we can give you some other painkillers in the form of patches as well. But usually we give them in the case the patient cannot tolerate morphine or are having some renal impairment. So if she is not able to tolerate morphine and if she is having some renal problems, we will give fentanyl patches.
Yeah.
Doctor, is there any alternative to the oral morphine? When she asks you to alternative to the oral morphine, this means that she needs to hear about other routes of morphine. So you can tell her right now about the infusion pump. Okay. This infusion pump, it will be a pump injected under your skin and will provide you with a fixed dose of insulin, fixed dose of morphine regularly, every day.
Okay.
Doctor, and we usually prescribe it in case the people are having tolerance to the oral morphine or are having some problems with oral morphine. So any problems with oral morphine or any problems or any tolerance, we usually give the infusion pump.
Okay.
Okay, doctor, will it be addictive to me? If she asks you, will I addict to it? You will simply tell her, people who will addict this are the people who take it for psychological need. But in your case, I mean the people who choose to take it. But in your case, you did not choose to take it. You are taking it for your physical issue or your pain, I'm afraid. So she is obliged or she is forced to take it, so unlikely to addict it. The people who will addict it are the people who are taking it for psychological satisfaction. Okay. What about the other thing you can offer to her? I mean, now I addressed her pain. You can also provide her with bisphosphonate and physiotherapy. Bisphosphonate and physiotherapy. Bisphosphonate and physiotherapy. Why bisphosphonate? To strengthen the bone, because you know that this pain is usually due to the bone weakness, due to the metastasis of the cancer. So you can provide her with bisphosphonate. And you can also tell her that we can provide you with some physiotherapy. Last point, if you ever have time, you can offer her some support. We call Macmillan nurse. Macmillan, I'm writing it.
Yeah, Macmillan.
Macmillan nurse. They are specialized nurses in this case for the people who are in the stage cancer to offer them some support, psychological and physical support, and supervise their care and treatment. So if you ever have few seconds remaining in your station, you can offer here some support and some nurses and some like this.
Okay.
This station is coming recently as well as prostate cancer. So the only difference is that he is male. This is the only difference. He is male patient. But of course, the male is having prostate cancer, not breast cancer.
So
Very
Dr.
similar.
Ahmad, Dr. Ahmad, if this patient is having 8 or 9 severity of pain, she is coming in the ER and E.
Yeah.
Just my question is that after paracetamol, you are going directly to IV morphine or tablet morphine?
Oral morphine.
Oral morphine you are giving.
Yeah.
Admission and giving oral morphine, right?
You are not admitting here. Actually,
No?
this is elective, you know. Wait, I will tell you something.
Hmm.
Here in this case, actually, what you are going to do, she's having this pain since long. So you are just going to call your senior and we will discuss this to her. We will send her to do MRI and we will prescribe her actually the morphine. So simply no need to admission here. I mean, she is not rolling in pain in front of you. She is tolerating this pain since long, but she is coming here for another alternative option.
Okay.
For the other alternative option, you're going to give her morphine. But if you are really confused, you need to tell her that we can keep an eye for you for a while because we are going to shift you to morphine. This is a good option actually, because when someone is starting on morphine, they are likely to have depression. They are likely to have drowsiness. So you can keep here. We can keep you here for a while with us, okay? And we are going to prescribe morphine for you to be taken for a while, or to be taken later on.
Yes. Yeah, that would be better.
This station is very easy station, by the way, and the pass mark for it is no. This is not ethics, Dr. Zaid. Okay.
No, I was just wondering that generally it has been told that one by one step ladder, like a paracetamol if patient is taking or NSAID, then combined with codeine, it would be cocodamol.
I know. This is a pain ladder, but the problem is that in this case you have to be a little bit more wise here. Why? Because this patient is terminally ill. This is palliative care. This is not about the pain ladder anymore. This is sort of palliative care. And she's scoring the pain high. I mean, after a while, like after 1 week, she will definitely come back to you and ask for something stronger.
Okay, got it.
Okay, Dr. Ahmed, can I ask something?
Sure.
Yeah, one at the beginning of the taking the history, when Dr. Yasmin asked you, do you have anything else? You replied to her, well, I have diagnosed with breast cancer for the 5 years, and okay, so I think it's not controlling. So regarding the structures, can you just reply to the patient on, well, you mentioned something important, and I will come back to this one. Can you reply to them, and you will continue with your differential diagnosis questioning?
No. This is part, you mean the pain management, I will address it, and after that back to my differentials?
Yeah.
No, don't do this. This is part of your management. This will affect your structure. You have to speak about any management. The only way you can give painkiller is if the patient is uncomfortable to talk, because you need to talk to them. But if the patient is comfortable to talk and if the patient can speak and say.
No, I meant that. Can we rephrasing the structure or what's the patient saying? Rephrasing has been, or the stress on the important words he or she bring it to us.
For example, give me an example. You are
like, for example, for example, I have chest pain. The chest pain is dull and it's right side and it's radiating to the back. And then can I summarize to the patient? And then when you said that you have chest pain, this chest pain is right side and it's radiating to the back. Anything else like this one?
Yeah, okay.
Or tell me more. We can do this way of asking the question, right?
Yeah.
Yeah, sure. So there's no problem in this one.
No. This is actually, you have to elaborate still the back pain, because this is your data gathering. I mean, do not assume that this is just because of the metastasis. No, you still have to, okay, listen again, to sum this station up again. To sum it up, number one, you have to elaborate the back pain. Number two, ask about anything else. Number three, ask about 2 red flags, like the neurological symptom and the coda equina. This is number three. Number four, you have to ask about medical conditions. She will tell you breast cancer.
Okay, but you know, initially she mentioned that well, I have been diagnosed with breast cancer, and this is for the 5 years ago, for example, like this one.
Yeah.
So she give me the past medical history initially. You know, when I asked her, tell me more about your condition, she gave me just you know, she gave me just
no, it's just you mean in your case it happened to you?
No, it doesn't happen to me. But sometimes because of the stimulator, when you ask him, tell me more, please, about your case, about your condition, he will vomit it to you all the knowledge he has about the case. For example, he will put something, he will give the pain and the dysuria and the past medical history and for example the job as well.
Okay, this is a good point, Dr. Zaid. Now, in this case, you'll tell the patient, I'm so sorry to hear that. This must be real difficult. I'm going to talk about it to you in a while. But just let's speak about your back pain first, because I see that this is bothering you more right now. So now, you know, simply you will start with the presenting complaint rather than the long issue. Remember, in the past station, he's having BPH since 3 months. What is more wise, to elaborate the thing which brought him here right now, or the thing which he is having since 3 months?
The thing which brought him right now because of the UTI.
Yes, exactly. That's what I'm saying.
Yes.
So now we are telling him, okay, we are definitely coming into that in a while. It seems to be quite distressing. But tell me more about your back pain first. So you will elaborate the back pain with S associating and differentials, and after that, you are going to talk to her about the breast cancer and the thing.
Okay.
The core of this station is to sympathy and empathy. She is very broken, and he also is very broken guys. So you have to keep sympathy and empathy all the time. This one is terminally ill. You are speaking to someone who is going to die. So please show sympathy and empathy all the time, please. Okay, let's move quickly to the next station, which is the ankle sprain. In the ankle sprain station, she is, you know, your FY2. Okay, so the FY2, your FY2 working in A&E. The patient came yesterday because she was having twists of her ankle. She fell on a glass. She fell on a glass, and her ankle. She slept on a glass and she fell, or she twisted her ankle under her legs. And she came here, and she has undergone X-ray. The X-ray report is with you right now, so you have to disclose the test results to her, the X-ray results. So here, this station is simply about disclosing the test results. So here in this case, you will take from her history. How can I help you? Doctor, I came yesterday, because she will tell you the full story. And how are you feeling right now? What about your pain? What about your swelling? So this is normal. Like, for example, the reason of visit and the current condition. How are you feeling right now? How is your pain? How is your swelling? Are you able to stand up? Are you able to bear weight? She usually improved. Okay, some past medical history from her as well. Inconclusive. And the job history, she is working as, I think she is working as a babysitter or something. So now you'll tell her, thank you for bearing with me. I need to have a look at your ankle again, or at your feet. You have to examine. After that, you're going to tell her, we have done X-rays. You actually, in this cubicle, you'll find an anterior-posterior view, AP, and lateral view. So you are going to tell her that we have done X-rays, and as you see with me, okay, actually here in this case, you can pick up the X-ray from the table and try to show it to her. Like this. Let me open the camera and tell you how to do it. You're going, for example, you're going to do this to her. This is your X-ray. As you see here, we expect, for example, if there's any fracture, we expect like a black line, thin black line in the bone, if there's any fracture. In your case, thankfully, there is no fracture, no black line, which means that there is no fracture. Before, again, I'm sorry, I forgot something. This is your X-ray. This is the anteroposterior, which we call front view, and this is lateral, which we call side view. In both views, we can see there is nothing in the X-ray. Oh, the video is not open? Wait. Thank you for telling me, Dr. Ayla. Can you see me right now? Can you see me?
No.
Really? I think there's a problem with my
No.
camera. Dr.
Oh,
Muniba,
Muniba can see you somehow.
Muniba, can you see me? Yeah, okay. So maybe because of...
Yes, I can.
Okay.
What
So
about me?
it's okay, it's simple. Simple. I will tell you. You just simply pick up the X-ray and you will tell this is front view and this is side view. We can expect there is a fracture if there is a black line in the bone. Very simple black line or thin black line, which is not the case in you, which means that your X-ray is fine. So doctor, if there is no fracture, what it could be? Now you will tell her that it could be something we call ankle sprain, which is very common in the sort of injury you had. What is ankle sprain? Again, remember the sprain definition? It is an overstretch of the ligaments beyond its limit. What is the ligament? Ligament is band of tissue. I will write it to you. Band, please remember this definition, band of tissue around the joint. Band of the tissue around the joint. Sorry, wait. Doctor, what I'm supposed to do right now? Now we will give her some advices. The treatment of the ankle sprain is summarized in the word pay price and avoid harm. I'm writing it to you. Pay price and avoid harm. Pay price means that I would do price, and avoid harm, which means that I'm avoiding the HARM. So let's speak about the price. For the P, I'm going to give the patient painkillers. This is number 1. So I'm going to give the patient painkillers. Number 2, the R. I am going to advise them to rest. Number 3, for the I, I'm going to tell the patient to apply ice packs on the affected part. For the C, I'm going to ask them to compress by a bandage. Bandage here is to limit any swelling or limit any fluid collection or limit any edema. And the E is for elevation. I need to ask the patient to elevate the feet for the swelling to be relieved. So again, painkiller, rest, ice packs, compression, and elevation. Avoid the harm. Avoid the H, which is the heat. The heat will harm the joint. Okay? Okay. And I also advise the patient to avoid running and avoid massaging and avoid alcohol. So heat, alcohol, running, and massaging. How long will it take? Usually it takes around maybe 4 weeks. Again, any sprain can take about 4 weeks, from 3 to 4 weeks, and it differs from one person to another. But to be fully able to walk back again and to do exercises, it may take up to 8 weeks. I mean, to do exercise, it may take up to 8 weeks, but usually to use it back again as normal, it can barely take you 2 to 4 weeks, and it differs from one person to another. Do not remember times, only try to say few weeks, like maybe a couple of weeks, because you'll be confused. Okay, so doctor, I have one concern. Doctor, yesterday I was told that, yesterday I told you that this happened to me in my workplace. I need you to provide me with a sick note. Remember the station of changing sick note? You will ask her, may I know why? Doctor, because I'm a single mother. Doctor, I was absent from my work today or yesterday. We can provide you with a sick note. Sorry, for yesterday. Doctor, but I want to leave. So this lady wants a leave. So she wants you to provide her with a sick note to give her a leave from the work, a paid leave. You can tell her, I'm afraid this is illegal. May I know why? Because we are not entitled to like change the report. Doctor, but I'm just telling you to write, doctor, I'm having a trauma. I'm having a trauma, doctor, I cannot walk. And this, okay. She needs you to prove that this note or this trauma has happened in her work so that you get paid by her workplace. So you'll just apologize to her simply and smoothly, and you are going to tell her that I cannot do this, but what we can do to you is to provide you with this letter. I mean, this letter, the GP can provide you with a letter, and you can provide this letter to the local council. So we can send a medical report of your case to GP, and GP can contact or send the report or forward the report to the local council. And you may be entitled, or they may give you or offer you benefits in the local council. She will keep telling doctor, shame on you, doctor. I'm a single mother and you're not supporting me. This is how you speak with the people. I'm sorry, I'm not in a position to do this. This is our ethical rules. We need to respect them. So you keep apologizing to her all the time that you can't do it, and you can offer her or you can send her to the local council and benefits. Okay, next station, pen removal, preoperative assessment. Preoperative assessment, guys, in this station is purely preoperative assessment. Okay, for the preoperative assessment, I have to tell you one thing. Preoperative assessment, guys, you have to ask a very good history. Do not overlook the history here. The history is the core of this station. So if you do not ask history, you are not going to pass it. After this station, we'll do the post-operative and the vascular surgery bypass, each one in 5 minutes. Okay, so for this station, I'm going to ask the patient, how can I help you? Doctor, I come here for my pen removal process. That's great. May I know why you had this operation? So he will tell you that he had a fall and he had this operation, which we put a pin, and he was supposed to remove it right now. So reason of visit number 1. Number 2, current condition. Do you have any pain, any swelling, any, for example, any problem with the movement right now, any difficulty walking, anything? Ask him about the things. Any problem in the bone is pain and swelling and limited mobility. Pain, swelling, and limited mobility. So you have to ask these 3 questions at the current condition. Okay. Very important here. The core of this station is to ask him the past medical history. Why? Because this is the most relevant thing for any pen removal or any perioperative assessment. You will ask him, do you have any medical condition? He will tell you diabetes. Full elaboration of diabetes. Like what? I told you that I will send it to you. Okay, so I will write it on WhatsApp right now after the session directly. You will do full elaboration of diabetes, but you will find that he is receiving insulin. So ask him about any other medical condition, like what? Like, number 1, any high blood pressure? No. Any high cholesterol? No. Any epilepsy? No. Any stroke or mini stroke? No. Any heart problem? No, as well. Any asthma or chest problem? No. You will also ask him about any liver problem? No. So full systematic review. Full systematic, you will pick up each and every system and ask about its relevant disease, because this is pre-operative assessment. But please do not ever miss to ask these 2 questions. Most of the people will miss them, which are any loose dentures, again, loose dentures and problems in the neck, and problems in the neck. Can anyone tell me why I asked these two questions? Dr. Muniba, can you tell me?
Yes, we're going to intubate the patient, so we need to know that is she using loose dentures or any problem with the neck, short neck. That
Why?
could be one of the problem for anesthesia. For passing the intubation with you.
Exactly, the intubation. I'm asking this for the intubation. This is very important. So this is for the intubation. So I need to ask these two questions here. Okay, now I will ask the patient, do you take any medications? Very important in the medications to ask about steroid. And very important as well to ask about any blood thinner. Okay. Did you have any other operation in the past? Definitely, he had the operation of pen insertion. You'll ask him about any outcome. Or I told you in any surgery station, I need to ask about any previous surgery. So he would tell you this, doctor, it went well, but the problem is that I felt sick after it. Why did he feel sick? He feels sick definitely because of the anesthesia. So you will tell him that this time we will prescribe you anti-sickness medication. Very simple. Ask about the lifestyle, smoking and alcohol only because these are the things which can interfere with the healing. Okay, now move to the examinations, full body examinations, everything. But most importantly, do not forget the BMI and the blood pressure, heart, lung, tummy, all the systems. But please do not forget also as well to do something we call MRSA screening. Do not forget to do MRSA screening. Again, do not forget to do MRSA screening. We still are having two stations which call MRSA and Clostridium difficile sedate. We did not discuss them so far. So MRSA screening, you have to do it for any patient before hospital admission. We need to do MRSA. So I'm going to examine your skin for any infection. And I'm going to check your airway as well. Okay? Okay. MRSA. MRSA. Okay, no problem, Dr. Maria, no problem. No problem at all. Take your time, Dr. Maria. MRSA, methicillin-resistant staph aureus. Masih, you entered this exam before and you should know about one of the most challenging stations, which is the MRSA. Okay? Okay. So, which investigations? Full body investigations as well. All the investigations that come in your mind, you will mention them. Blood, urine, and X-ray, and ECG as well. Then in the disclosure, no one like it. Really, this station is quite angry patient station. So in the disclosure, you will tell him that he is fit to undergo the surgery. However, we need to do one precaution, one caution. What is this? We are going to stop the insulin. Stop drinking and eating 8 hours before the operation, for which we are going to stop the insulin. What he was going to do again, you know, guys, before any operation, he will need to stop eating and drinking because of the general anesthetic to avoid aspiration pneumonia. So to avoid eating and drinking, he needs as well to stop insulin. Okay? And how to stop insulin here? He needs to stop only the morning dose of insulin. So he will go to stop the morning dose of the insulin only. I mean, because it will be daycare surgery, it means that he will start the operation maybe by the afternoon. So this means that he needs to stop the morning dose of insulin. But the night dose, I mean the dose of the day before the operation, he will take it normally. So he will only stop the morning dose of the insulin or skip it. So this is a disclosure. Number two, I told you, anyone who's going home after the operation, there's an important question I need to ask. which is
Whom do you live with?
perfect. This is the most important because of the anesthesia. Because actually this patient needs to be accompanied by someone.
Yes, exactly. I was going to say that they are not letting a patient go unless they arrange someone to come
Exactly.
and pick up.
Exactly.
They are not even considering to go into the operations.
Yes, exactly.
Yeah.
So this is what you should do. You always ask about this. Why, doctor? Why it's important? Because actually we need to make sure that nothing of the complications will happen to you. That's why you need someone to be by your side. Which complications? Okay, at least like the severe pain, the bleeding. You mean you will mention here about the DVT and the pulmonary embolism. Okay, so you'll mention here about DVT and pulmonary embolism, and you can also mention about the dizziness. However, usually we keep them in the recovery room for a while after the operation to make sure that they are not feeling dizzy anymore. However, you still need to make sure that everything is fine, so he needs someone to be by his side for the first 24 hours after the operation. So you will tell him that we need someone to look after you in case you develop any leg swelling or redness or any severe pain or shortness of breath. He can ask you, doctor, will be there any pain after the operation? You can have pain, but we can give you strong painkiller, like anything. Some other question he can ask you, what are the other complications? I told you the complications of the surgery are like any surgery. What are the complications here? Could be number one, I told you dizziness after the operation due to the anesthesia, for which we are going to give you anti-sickness medication. Or sorry, we are going to give you oxygen. For the sickness itself due to the anesthesia, we are going to give you anti-sickness medication. Some other complication, or the most important complication for any surgery in the leg, is blood pooling in the leg. Blood pooling in the leg due to lack of mobility or due to inactivity. This can lead to pulmonary embolism. So what we can do, we're going to give you blood thinner injection and carefully move your joint. So for any leg pooling or blood pooling, or when I need to address the pulmonary embolism, I need to give blood thinner injection and carefully move the joint or move the leg to avoid blood pooling. He will ask you, when can I go home? This is a daycare surgery, so he's supposed to go home by the end of the day. However, before sending him home, we need to give him some few advices. Any surgery, I advise the patient about number one, how to wound care, how to care his wound. Number two, the physiotherapist will speak to him about the movement, how to move about after surgery, and also he will be seen by the GP in 2 weeks. Usually the GP follow you after any operation after 2 weeks. So again, number one, wound care. Number two, physiotherapist to see how to move. Number three, GP review in 2 weeks. And he can be seen by specialist or by the surgery department after 6 weeks. So GP review after 2 weeks and surgery review after 6 weeks. So for anyone who's going to be discharged, number one, wound care. Number two, physiotherapist will speak to him, and also can be occupational therapist as well, you can add it. Number three, and very important, GP review in 2 weeks and surgery department review in 6 weeks. This is enough for today. We will be left with 4 stations from surgery, at least 8 stations of surgery tomorrow. One of them is ductal carcinoma in situ and the breast fibroadenoma. Those are 2. Later after sigmoidoscopy, this is number 3. Beside the hernia operation, this is 4. And post-operative wound infection, 2 like 6. And 2 operations are 8 stations for the surgery tomorrow. We'll be left with them, together with the earwax. So there are 9 stations, 9 surgery stations. Beside the gynae, which are like maybe 8 stations. We're going to do them tomorrow. Sorry, they are 7 stations. We're going to do them tomorrow as well. The gynae, the OBG. Okay. So tomorrow will be a little bit long day for us. For that, I just too much seriously, because we are discussing all the stations, the new and the old ones. I mean, no course will discuss to you. No course will definitely discuss to you